Yeah, Rajesh is the other chair, sir. So we were waiting for him. So he has come up. So you can start, sir. Over to Sanjeev sir and Rajesh.
Welcome back to this SCAN program in which we are meeting the colleagues from 1999 batch. Is that right? And
Yes.
we have already had 2 excellent talks, and today is the another marvelous one which we are all expectantly waiting. So over to Rajesh to introduce Anu and then take from there.
Rajesh, I'm waiting to be
Can you hear me?
We are seeing but not hearing.
Can you hear me now?
Yes.
Yeah, you are clear.
Okay, great. It's my great honor and delight to introduce my dear friend Anu Jacob. So you can see this was a picture taken in front of the famous Taj Mahal in 2001, and that shows the bond between 3 of us. I'm just lying, okay? Okay, so Anu Jacob completed his DM Neurology from the Sree Chitra Institute in 2001 with famous colleagues like Bobby Varki and Mahalakshmi. Subsequently, he went to the United Kingdom and joined the famous Walton Centre, where he continued his further specialist training in neurology. And he subsequently completed a clinical fellowship training at the Mayo Clinic in demyelination. Since then, he developed a passion for neuromyelitis optica and started a world-class clinical service for the entire United Kingdom, for which he is the lead neurologist. He brings more than £1 million budget for the NMO service. So I looked at his publications. He has nearly 100 publications. Interestingly, 70 of them are in NMO. Wow, that is fantastic. So the most charitable assumption is that he is highly focused. But the most malicious assumption is that he has OCD. But I think this is one of the highlights of his career, where he was awarded the Royal College of Physicians Excellence in Patient Care Award in 2016 in the consultant category. And you can see the comments from the judges. I'm going to read it, but it is excellent. So congratulations, Dr. Jacob.
Thank you.
So this is just one part of Anu Jacob. There is another half which most of you are not aware of, but I am the victim usually. He recently developed an interest in singing, and he sends me these small clips where I am supposed to give the honest feedback. Finally, I was fed up and I gave this final feedback. Anu, fantastic. I could see islands of brilliance in rhythm, sprinkled with the occasional steady voice, and this is quite unique and different. And then he stopped. Well, how many of you know that he is a marathon runner? He has completed several half marathons, and he completed the famous full London marathon. If we try to do this at this age, I am sure I will develop a myocardial infarction. Well, he completed a travel from London to Paris in his bicycle, and you can see the famous Eiffel Tower at the backdrop. Well, he is the captain of his hospital cricket team, and every year they win when they play against residents of a senior long-term care facility.
That's not true.
Well, Anu's psychology is that if something is difficult to conquer, he makes it a point that he conquer it. So he conquered at least 3 mountains, and the next one is Everest. And he is an excellent dancer, but the only difference is that he dances only with a specific gender. At the height of middle-age crisis, he bought a Harley Davidson. Well, he was in constant search of his soul, and he recently traveled from Kashmir to Kohima and tried to explore the heart of India. And I'm so glad that he has a Kuri and a Rudraksham, and that was I was waiting for to see. But finally he went back and he saw that his soul was here. So this is his beautiful family with Liji and 2 brilliant boys and of course 2 dogs. Anu, we are so proud of you and looking forward to your talk.
Thank you very much, Rajesh. That's a very kind and generous introduction. Is my screen still visible?
No, you have to do it again.
Okay, so let me do that again. Okay. Now, is this visible?
No.
Okay. Let's do that again. Share screen. That one. Share.
Yes.
And that. While I just bring up my second screen.
Well, we can read what are the notes you have taken.
Have you?
Yeah.
Very good. Let me just bring the second screen and then. Should be working now. Okay, what screen? Can you see the screen now?
Yes, we can.
Full screen?
Yes.
Yes.
Thank you. So thank you, Rajesh. Thank you, Asha. Thank you, Sanjeev sir. So it's my great pleasure to feature in this. And as Rajesh said, I got a raging midlife crisis going on. It began a few years ago. I think most people in this age are Sudeep included. I can see Sudeep are in trying to get the max out of life. So there's a saying by Diane Ackerman that I don't want to get to the. She's a poet, American poet, and she says that I don't want to get to the end of my life and realize that I have traveled the length of it. I want to have traveled the breadth of it too. So I'm in the process of setting up some challenges, trying to accomplish them, and sort of some of them you win, some of them you don't. But so yes. So I've already given the location as to where I work and what I do. And I titled this as a confessions. So now that I've titled it as confession, I have to tell you at least one confession to begin with. So the one confession is that, when I was a resident in Chitra, I was very anxious during presentations. So I was petrified of some case discussions, journal clubs. So secretly, I used to take beta blockers. So before the morning case presentation, I used to go to the ward, bribe the sister to give me a propranolol, and I used to manage the presentation. I'm pleased to know that I've conquered my demons and I don't have to take a propranolol nowadays. And I haven't taken one for today. The content of today's talk. As I was saying, I had some mixed, conflicted plans. But I think most people expect me to talk about NMOSD and MOGAD, and that's what I am good at. So maybe I should focus on that. I had a whole 10 cases on difficult cases or things I made errors with, which I think we should bypass for today. But the last bit, I think, is something I'm passionate about and is really maybe something I can talk about, at least for the benefit of the younger audience who think who have an aspiration to become a disease expert. Maybe that's if time permits, and I'm sure we can manage that. it's always useful to have a historical perspective when you deal with any illness. It gives you the whole picture. So let me start off by giving you a slide on this. You know, in the beginning, if you talk about NMO, in the beginning it was all MS, right? Everything was MS, and Charcot described it. Devick described something about NMO, the initial cases, but in the absence of a clear biomarker or histologic evidence, it soon became severe. NMO remained as severe MS until 1999, when Brian Weinschenker, in a methodical manner, along with Dean Wingachuk, clarified that NMO is indeed a distinct disease. But Brian's ideas would have met the similar fate as Devick's had not Professor Van der Lenen described the antibody in 2004. And the rest is history. Now, you will know that MOG antibody was around in the 80s as a marker for of MS, really, but it soon fell out of vogue. Hans Lassmann, Chris Lennington, and the reasons for this are interesting too. Anyway, it fell out of vogue because the antibody was found in conditions other than MS and even in controls. Until 2007, when Kevin O'Connor from Yale University described the presence of a unique antibody that is against MOG present in patients with ADEM and not MS. And then now we realize that a proportion of patients who were seronegative for AQP4 antibodies in NMO are positive for MOG. So that is why there might be some confusion in people's mind as to the terminology, but this is the evolution of the disease. Now, why at least for our education purpose, why were these antibodies mistakenly thought to be present in MS? Well, it goes back to conformational and linear epitopes. Remember the antibody, the FAB end, you can bind linear epitopes, or you can bind conformational epitopes. So this is what happens in real life, in living beings. This is what happens. The three-dimensional structure of the antigen is what the antibody binds to. Now, when Hans and Chris used the techniques to identify antibodies, they used Western blots and ELISA, and they used the linear MOG as a substrate. And the sera of healthy persons have harmless antibodies that will bind to linear MOG, and that's what they picked up. While the pathogenic antibodies, which cause the disease, which actually bind to only the folded MOG. When Kevin used the newer assays, which use the conformational antigen, the antigen in the conformational state, he detected the correct the antibodies. And that is where it's a whole new revolution in our ability to detect autoimmune illnesses now, and largely because we have cell-based assays. What are we trying to do? There's this antibody circulating in our bloodstream, and we want it to bind to a target antigen. And for it to bind, we have to create an ideal antigen. And the ideal antigen, we should not compromise. In case of MOG, we have used the full length of the MOG protein. Now you can express these. You can make cells express these proteins using plasmids on their cell surface. So, and the plasmid codes for the full protein of the MOG, both the membranous component, the extracellular, and the intracellular component. So you make hex cells express these antigens on the cell surface. And now you take the patient's sera and you add the sample onto it. Now the antibody, the patient's antibody, and in MOG, the pathogenic antibody is an IgG1 subtype. Now IgGs have 4 subtypes, IgG1 to 4, and the IgG1 subtype binds. And then you have to detect it by using an anti-human IgG1 antibody, which in turn has a fluorescent marker. So when you shine ultraviolet light, you when the antibody is bind, the cells light up, and you can see in the neuroimmune assay which you have in India, this is the negative assay, and this is a positive assay. These are fixed cells or kill cells. The antigen is the presence of the antibody is indicated by the binding. And this is the live cell assay in which the cell is still live. Therefore, you can see the expression of the antibody all over it. And this is the representation here. You can see the hex cell, the antigen, the binding, the antibody, and the anti-IgG1, and the fluorescent marker. Once these antibodies created in the peripheral circulation cross the blood-brain barrier, and the mechanisms that are not quite clear. In normal healthy patients, healthy people, antibodies don't get across into the brain, but the barrier becomes leaky, maybe because of viruses, maybe because of T cells which are activated. And if this is a normal blood-brain barrier, we've seen these pictures many times: astrocytes, neuron, myelin, and MOG. In AQP4 NMOSD, we had the target, which is the astrocyte, and the antigen-antibody interaction in AQP4 NMOSD causes a lot of inflammation. It utilizes complement, and the damage is quite severe. While in MOG, the target is the myelin sheath in the central nervous system, not in the peripheral nervous system. The central nervous system, because MOG is a CNS protein only, and it also targets the oligodendrocyte. Complement interaction involvement is probably less in MOG disease. Naturally, once the antibodies are present, in some situations, the antibody may disappear if it's a monophasic illness. But in AQP4 NMOSD, the antibody once appears seems to persist perhaps throughout life. And maybe these B cells or plasma cells that produce the antibodies in AQP4 NMOSD are hiding away, or they are not in peripheral circulation. They're not easily accessible by the drugs that we use. So we really can't seem to cure these condition completely, and they may not die out too. So long-lived plasma cells may explain the persistence of disease in AQP4 NMOSD. This is a graph that shows the persistence of the antibody for an individual. Even low levels can cause the disease. But this is different in MOG, or so it seems. This is a Canadian study, and you can see this is the graph in which this is the time. This is a Canadian children with MOG disease, and this is the proportion of patients who are positive. And so day 0, everyone is positive. And as time goes on, the proportion of patients who still remain seropositive actually comes down. And by about a year or so, only about 50% are positive. And by 4 years, now only about 40% are positive. So MOG antibodies seem to disappear with time, the proportion of patients, while AQP4 antibodies tend to remain. And this has implications for treatment. The clinical features largely mirror the location where the inflammation happens. That's quite normal, isn't it? So as you can see, the highest representation of the antigen is in the periventricular areas, in the periaqueductal areas, in the brainstem, in the diencephalic region, and in the optic nerves and spinal cord. And therefore, all the core criteria that we say for AQP4 NMOSD reflects these things on optic neuritis, myelitis, brainstem, diencephalic, area postrema, and cerebral syndromes. In MOGAD, there seems to be 2 predominant phenotypes. You seem to have ADEM as a common phenotype in the in children, and with time, the ADEM phenotype seems to become less and less. So you can see the age in years here, and patients with MOG antibodies. So as age advances, the ADEM phenotype becomes less, while the opticospinal phenotype seems to increase. So adults may usually manifest with the typical NMOSD presentations, while children seem to have more of ADEM. What about criteria? I mean, it's nearly 4 years since the NMOSD criteria, and we're sort of familiar with it. There is a seropositive group and there's a seronegative group. And in But MOG, we don't have an official international criteria yet. But Mayo Clinic group has proposed a criteria in which the antibody is an essential requirement. So it's MOG IgG antibodies, along with the most common clinical features, which is ADEM, optic neuritis, transverse myelitis, brainstem, or a combination. As new phenotypes are being described, I'm sure they will be considered when a proper criteria will be developed in the future. I think the common situation where clinicians, neurologists will be called is to opine is, is this NMO, is it MOG, would be looking at MRI scan. Somebody comes with the demyelinating phenotype, and what is it? And MRI is what is going to usually decide. But, and brain MRI particularly. And it's important to stress that, if the MRI brain is usually normal or has only mild or non-specific changes, if the presentation is that of optic neuritis and myelitis. If the presentation is ADEM, then you're going to see brain lesions. But if it is optic neuritis and myelitis, you may not see much on the scan, so don't be surprised. And it is not very easy to differentiate between AQP4 and MOG on MRI scans, on brain MRI scans. But let's try. But to do that, we must first understand what a typical MS scan looks like. I'm sure many of you will be seeing MS, but let's quickly recapitulate. So you can see the typical periventricular lesions, Dawson's fingers, the S-shaped juxtacortical lesions. You can see the cortical lesions here. You can see the central vein sign in 7 Tesla scans, and the peripheral axial scan and the peripheral lesions. Let's look at MOG and MS side by side. Okay, so this is typical MS, and that is the MOG scan. So it's not, they are not similar, though there are some resemblances. Typical MS, typical MOG. Typical MS and typical MOG here. Can you see the pointer? Yeah, Asha, can you see the pointer?
No.
No? Can you not see the pointer I'm using?
No.
Oh, I see.
No,
sorry.
no.
Oh, I see. Okay. So let me just mirror displays. This should be all fine now. Apologies for that. What can you see?
Yes.
Can you see the full screen?
No.
No? Okay. Now, full screen?
Not yet.
Okay. So, screen sharing. No? No. Now?
Yeah.
Yes.
Yes? Yes. Good. Okay.
Yes.
So, you can, apologies for that. So that is so if you can, you've seen this, can you see the pointers now?
Yes.
So periventricular lesions, let me just minimize you guys as well. So yeah, so S-shaped subcortical lesions, cortical plaques. You can see the central vein sign. This is the axial scans with the peripheral lesions. And this is the MS scan, the MOG scan. These are the lesions in MOG. The differences are striking. Long cord lesion, it's long cord lesion and short lesions here. Now let's focus on scans in MRI in MOG and AQP4 alone. So you can see that they are not really typical of, taken together, these brain scans don't look like typical MS. There are similarities, but they don't look typical for MS. So here we go. So we can see, these unusual spots, tumefactive kind of lesions, oddly. Now this lesion here looks like MS, but the whole picture may not look like MS. You can see these lesions here. This is something we saw a few years ago. This is a patient who came with seizures and sort of encephalitic presentation. We've reported this, and so have colleagues from Japan, who in their patient, the encephalitis is sort of restricted only to the cortex. There's no, the deep white matter involvement is not there. Our cases mostly had deep and cortical, while these can only be unilateral and focal on the surface, like a gyriform change following status or so on. It can be bilateral, as you see here. Bilateral, as you see here. And this is another patient of ours with a focal area of encephalitis. So think about MOG in children or adults, young adults with a focal encephalitis, if they don't are negative for typical encephalitis workup. You could have lots of ADAM-like lesions. You could have cerebellar lesions, which are rather uncommon in AQP4 NMOSD. You have leukodystrophy-like lesions. In fact, we have a patient with leukodystrophy-like presentations. Now, I'm not saying you should go and screen every leukodystrophy for MOG, but the presentation is atypical. Tests are negative. Think about or the steroid responsiveness. Think about it. This is a long optic nerve lesions in MOG. You can see this is a T2 stir sequence. You can see that there is some involvement of the periorbital tissues as well. And in fact, when you give contrast, the periorbital tissue also seem to enhance on that side. This is called optic perineuritis. It's not very common, but it is probably commoner in NMO than in MOG than other conditions. And I'm not quite sure why. Maybe it's the inflammation spreading from the nerve into surrounding tissues. It probably is interesting to think on why you get pain in optic neuritis in the first place. Of course, the inflammation of the dura is responsible for the pain, but the stretching and buckling of the dura around the nerve is probably causes more pain. So if it's the anterior part of the optic nerve is what is mobile, isn't it? Close to the globe. So therefore anterior optic neuritis tend to be more painful than the mid or posterior parts, which are relatively immobile, and therefore even if inflamed, the dura does not stretch. So this is a MOG with a cord lesion. Sometimes you can get this H-like sign on that, on the axial scans. This is the extreme AQP4 NMOSD disease with a pretty significant cord involvement. And this is a typical MS with a small lesion, a small enhancement and a peripheral plaque. So quite extensive destruction. Now, probably milder destruction, but can happen the other way too. Do these lesions disappear with time? They do. Majority of cases, maybe because these lesions are rather edema or there are significant repair mechanisms, these lesions disappear with time. So same patients here, lesion disappears over time, pretty much gone. Long cord lesion, also gone here. But not always. This is a patient of ours with severe relapsing MOG, and he had a scan prior to developing the disease. And during the acute phase of the cerebral involvement, he had actually seizures and hemiparesis and all that. And with time, you can see he's sort of atrophied, and he was left behind with the hemianopia. The same patient, you can see he had other attacks. You can see the Wallerian degeneration here, and he had a hemiplegia as well. So MOG is not mild. Some patients are quite significantly disabled. There are rare presentations. Conus involvement, aseptic meningitis has been described, but I think it's a small parenchymal involvement with a significant meningeal inflammation. MRI negative myelitis because the scans don't pick up the changes, I guess. Probably myeloradiculitis, cranial neuropathies, and some of these will stand the test of time. They will indeed be considered as variants of MOG, but some may not be related really, and we have to do large cohorts to see. I'm not sure how these, maybe it's me drawing on these lines on the screen. So I think I've given you enough information to compare AQP4, MOG, and relapsing MS. But I must say that nothing except the antibody is specific to AQP4 versus MOG. You really cannot often differentiate the two. But let's try to separate them out. So I'm going to focus on MOG here, and you can compare these two, right? So MOG is at least as common as AQP4 NMOSD, and MS is clearly much higher. 1:1 ratio largely in MOG, male to female, while AQP4 is a predominantly female disease. All races, but Asians and blacks may be more common in AQP4. Young people more in MOG, while adults are more in AQP4. Other autoimmune illnesses are common in AQP4, a viral prodrome commoner here. Because AQP4 is expressed in other tissues, you can have involvement of the skeletal muscle, cardiac muscle, cochlea, retinal ganglion cells, but MOG doesn't cause that because MOG is it is a CNS protein. It does not express in any significant degree in an accessible manner in the peripheral nervous system for the antibody to bind. Optic neuritis we discussed, posterior, bilateral and common and anterior in MOG, and it can be anything in relapsing MS. But painful optic neuritis is more common in MOG. ADEM common in MOG, cerebellar lesions more common in MOG, children more involved with MOG, seizures more common in MOG, maybe meningitis. And actually we described this itch, severe itch in NMO. 25% of NMO with myelitis has very severe itch, and it can be a warning sign of a relapse. Brain lesions, deep gray lesions, long cord lesions can be similar. Area postrema seems much commoner in AQP4 disease. Conus lesions, rarely leukodystrophy-like lesions. We talked about this. Conversion to seronegativity is commoner in MOG and rare in AQP4 disease. Other autoantibodies are commoner in AQP4. CSF bands are present equally in both. The chance of relapse is close to 100% in AQP4 NMOSD over time. That's what we think. That's how we treated all of them. While in MOG, as we will see, the 50% relapse with 4 years, but do all of them relapse? And the antibody assumes significance. Disability is acquired early in NMOSD, AQP4 NMOSD, while in MOG, good recovery is common, but some patients can be quite disabled. How do we treat the condition? So my approach is that in every demyelination I see, I think because the outcomes are poor for these two conditions, MOG and AQP4 NMOSD, I always think, could it be that? And if I think it's a possibility, then I want to treat aggressively. And I know that time is precious. So I tend to treat pretty well. I give high dose steroids. And if I'm in doubt, or if I'm not in doubt, that this is related to this, I give early plasma exchange. And the response can be pretty good even up to 3 months. In my mind, I think of it like this. I think of plaques in demyelination or possible demyelination like thrombolysis in stroke. There is I think time is spinal cord. There is a window of opportunity here. And if you allow the inflammation to fester, you're probably going to lose things. But in the process, often you may end up treating patients who don't actually have demyelination. But so do we in stroke, don't we? So you thrombolyze, everywhere in the world, people thrombolyze migraines. But the risk benefit is probably favorable in favor of thrombolysis, isn't it? So I kind of take the approach towards that. Maybe I'm a bit more proactive and aggressive. But over time, I've realized that I have helped more than harmed. And I continue the steroids till the antibody results return. So a patient comes, you treat it the best, send out the antibodies, and if the scans are typical for MS, I wean it off because we know MS the repair mechanisms are much better. But if the antibody comes back as positive, then I continue the steroids for few months at least. Because I think of it like myasthenia. Just because we stop, the antibody is not going to disappear. The inflammation is not going to go away. So I would think of it as treating myasthenia and the damage will be ongoing, and there is a role in steroids in suppressing it. In the UK, we treat acute NMO like this. We treat all patients who are positive or relapsing seronegative NMOSD with one of these first-line drugs, and then go on to rituximab if they relapse. So 2 ways of doing rituximab. You give a standard fixed dose on every 6 months, 2 doses, day 1 and day 15, repeated every 6 months. So year 1, year 2, or, and this is what we do now for good reasons, we give the initial 2 doses. It's a variable dosing, so you give the 2 doses, and then you monitor the B cells in the peripheral circulation, basically blood. And if the B cell count is less than 1% of the total white cell count, then you start retreating it. Because by the time you give rituximab in a couple of, in a few days time, or within it will go to 0, and then you wait for it to come back. My opinion is that there is no point over treating these patients because they get complications. So currently we do this strategy, and it looks like we have to retreat some patients only once in 2 years with 1 gram of rituximab, which is amazing. So this is probably implications for other conditions like MS, where we are giving ocrelizumab every 6 months. I think it's over treatment. And we have done some work on this. We looked at our own patients here, and we found that the variable B cell monitored lower dose was similarly effective to the fixed higher dose rituximab. And we were giving 1.5 infusions per year versus 4.5, and the cost was less, and the risk of hypogammaglobulinemia and infections were significantly low. But we have the whole new generation of NMO drugs here. We have inebilizumab, which is a drug that depletes the B cells, binding an anti-CD19, while rituximab is anti-CD20. We have cetralizumab, which depletes the anti-IL-6, binds to the anti-IL-6 receptor. And IL-6 is required for B cell maturation. And then we have complement inhibitors, because complement is significantly involved in the disease, in causing the destructive inflammation in acute NMOSD. We have these, all 3 drugs have been in trials, eculizumab, cetralizumab, inebilizumab, and they will come to the market very soon. IV, subcutaneous, and intravenous, every 6 months, every month, and twice a month. Overall, I won't go through this in detail, but the short message is that they're all effective. The 3 trials here, one of them, inebilizumab, had only the placebo versus real drug, and 73 and 77%. Eculizumab had it was an add-on study, that is, there was nobody on only placebo, and at 94% risk reduction. Cetralizumab had one of each study, both placebo and pure placebo and placebo plus IST, and those are their results. All of them are effective. Now, I say this often. NMO is waiting for drugs in NMO is like waiting for buses. You wait for a long time, and then nothing comes, and then 3 of them come at one time. And sorry. And there are the destination is same for all these buses. They're all going to help achieve remission. But some of these buses are going to be quicker. Some will have a more comfortable ride, i.e., less side effects. Some will be convenient, and there's no stop. It's not a shuttle service. You go straight to the. But irrespective of those differences, the tickets for these buses are going to be really expensive. These drugs are going to be quite expensive, and I hope the industry does correctly price them for our markets. What about MOGAD? Now, how do we prevent relapses in MOGAD? Well, first of all, we have to decide if these patients are going to relapse or not. So, does seropositivity predict relapse? If you take these patients, okay, so this is a Canadian study again. So you take the patients who are all positive and see what happens to them over time. This is the time to the second attack. Now, if you turn seronegative, then the chance of a second attack seems low. And by 6 years, only 10% of those who were seronegative had a relapse. While if you're seropositive, you remain seropositive, that means the subsequent sample also was positive, then by 6 years, the prediction is that you would have about 60%, 40% will relapse. So the antibody seems to predict the occurrence of a relapse. Not in everyone, because there is still significant proportion haven't relapsed, but it is a possibility. And a similar result has seen in a US study of about 50 patients. Again, it is the same graph. You have the patients, this is all patients of ADEM that they saw. And this is time to a second event. Some of the patients were positive for the antibody and they remain positive, and then they had further attacks. Some patients who are positive turned negative and then they did not relapse. But some patients did not have the antibody to begin with. This is a cohort of ADEM. And they went on, some of them went on to have relapses. They had other conditions or MS and so on. So the antibody does seem to predict relapses in a majority of patients. So in this UK study, using a prolonged taper of steroids seemed to prevent relapses. Perhaps, as you saw, most of the relapses seem to happen in the first few months. You can see the curve dropping down here in the first few months. So that may be an explanation. So how do we prevent relapses in MOG? Well, the principle is that in AQP4 NMOSD, severe inflammation, antibody will persist, higher chance of relapse. So we treat almost everyone. While in MOG, the inflammation is less, the antibody can disappear, and there's an overall a lower risk of severe relapse. So we can try to be selective in deciding who to treat long term. And if you need an algorithm, I would recommend the UK algorithm. This looks complex, and I'm sure it's a small font, but if you can zoom in if you can. So we have MOG antibody disease. Patient comes, we give steroids for 6 months, and then we retest. You retest and the antibody is positive. So if it's negative, then you take off the drug, we stop the drug. If it is positive, then you have if the patient has already had another attack, or the initial attack was quite severe, or the patient is tolerating steroids quite well, then we say, let's continue, nothing is lost, and the patient is not having side effects. And then in 12 months, we repeat the antibodies again. And if they are negative, we stop the drug. But if they remain positive, or if they've already had a relapse, so this the illness has declared itself to be relapsing, then we continue immunosuppression, or at least have a discussion about it. So a proportion of patients who have persistent antibodies or have relapsing disease, we continue to treat. Well, a good proportion whom it's a monophasic illness and the antibody has disappeared, we stop the drug. And what drug shall we use? Well, with respect to MOG, we are back to square one. We are using all the original drugs that we had for NMO: steroids, mycophenolate, azathioprine, IVIG, rituximab. Rituximab, surprisingly, is not as good as we thought it would be, because the efficacy is excellent in AQP4 NMOSD. While IVIG, which we haven't really used much in AQP4 NMOSD, seems to work well for MOG. And there are cases in between. When you don't have, doesn't look like MS, it doesn't look like an NMO, what is it? Somewhere in between. In general, experts disagree on how to manage this, but by and large, if in doubt, we treat as NMO, and the options really are, drugs like rituximab, which can work for MS, NMO, or most of the conditions. To summarize that section, really, MOGAD and NMOSD have many similarities but are distinct diseases. Cell-based assays are specific and sensitive. Suspect NMOSD and MOGAD in ADEM and variants. When scans look demyelinating but not like MS, atypical encephalitis. If scans and clinical features are typical for MS, then probably not worth testing, at least in the Western setting. But in India, where NMO and MOG, AQP4 NMO is more common, or similarly common, let's say, compared to MS, then it might be worth testing more often. But in UK, if the scans look typical for MS, we don't bother. It is difficult to distinguish clinically or radiologically between AKP4, NMOSD or MOGAD or MS sometimes. Therefore, treat all the index events well, while you wait for the antibodies to return. While recovery is good, disability does happen, particularly so in AKP4 disease. And almost all AKP4 NMOSD relapse, and about 50% of MOG will relapse. Persistent MOG is a predictor of relapse, so there are still some uncertainties. Most AKP4 NMOSD require treatment. MOGAD treatment patients, some of them require treatment, and conventional drugs are effective. But many cases are individual. You have some decisions are not very easy, and we have to discuss pros and cons. And sometimes it's reasonable to watch and wait. For example, a patient who is quite intelligent, understands the disease, has a mild and almost complete recovery, you needn't retreat, provided they can access services pretty quickly if they have a relapse. Yeah, there is some fine tuning required. If I'm allowed to, I'd like to go on to the second half of my talk. Is that okay, Asha?
Yeah, definitely.
So as I said, this is the talk about confessions, right? The second confession I wanted to make is that I have made far more mistakes than you think I have made. There was a whole set of cases that is meant to follow, but I'm not going to do that, but perhaps for another time. The third part of my talk is really something I think I should share. And I gave this talk recently to my colleagues here in the institute, and people were asking this question, look, how did you manage to set up a service? And because they have all seen me here for the last 17 years. I was a fellow here with Mike Bogle, and this is my first poster in the ABN. And you know how posters are in national, international meetings. You do all this work, you create this poster, you carry it all the way to the conference, you stand in one corner, and nobody even often turns up and says hello. So I have done that quite a bit, but sometimes fortune favors the brave, and a lot of my experiences are from hindsight, really. And I'm sure there are many experts in the audience, and they might have similar views. But I just wanted to share my thoughts on how one can try to create and generate expertise in a narrow field. The first thing to say is that not everybody wants to be an expert. It's perfectly fine for people to be, people may not enjoy the hassle of becoming an expert. It requires time and commitment. Clinical neurology is fascinating and fantastic, and the joy that you get from that is probably more than sufficient for most people. But some people maybe want to focus on something very narrow and try to see if we can advance the field. And really, it is for people like that who have an interest in this. I was hoping to give some guidance. But you really have to decide, are you really interested in this? Do you really want to put time into this? And this is the happiness pie, what really makes you happy. This is your large pie. What proportion of that pie is made up of your desire to be an expert. And if it is not part of your pie, then don't even bother. So the first is to ask yourself, is it worth your time and effort? But if you really are in the category of person who feel that, I really want to focus on one thing, then the first guidance is, you don't need experts to treat the common cold. Okay, you want to find an illness that your peers need help with. It should be a difficult topic. Most people, neurologists, and I don't need help in treating standard Parkinson's. But somebody comes to my clinic with postural instability and severe dyskinesias, I might struggle a bit, and I will struggle a bit. So that is where I need help with. And the same applies to a lot of conditions. Those patients that you think are the most difficult, is difficult for everybody else too. So that is where you want to focus and try to become an expert. And sometimes rare diseases offer that great opportunity by virtue of its rarity, because people don't see enough. We don't know how to manage them. We don't know the clinical manifestations of all of them. So it is great if you could focus on either a narrow area of a big disease, and a difficult narrow area of a big disease, or an uncommon disease. The next point is, will it truly get you out of bed? There is no point in taking up something if you're not passionate about it. And you will know what you love doing, what you love, what kind of illnesses do you see. And some patients will touch you. You realize that this is an unmet need. And this is where you can focus and make a difference. There's a Japanese concept about ikigai, something you really enjoy, something you're really good at. It helps the world, and you can make a living from it. And the combination is called, what gives you that is called ikigai. The French say it's the raison d'etre. It's a reason for living. So I'm sure you have, at moments in life when you see patients, with difficult problems, you think, I think I can make a difference, and that's probably what you will enjoy in doing. So choose something wisely, what you want to work on. Experts need to know your subject. And there is no excuse for that. As neurologists, we thrive on this. We are great at amassing knowledge, even subjects and cases that are far remote to us. We're interested. We want to accumulate knowledge. We want to know all the variations. So NMO is a rare disease, but there are a lot of people attending today. So it is uncommon. We love it, and it should not be a problem for that. But once you choose your field, you have to really know in depth. It was relatively easy for me when I began, because there were only about 300 publications in NMO, and I read all of that. And over time, I have kept up to date. You can subscribe to things like PubMed sends you updates regularly. If you can put a topic of interest, you can have a mailing. I regularly look at conferences and so on. Keeping up to date is really important. Experts actually know the past of the illness, know everything about your illness from the past, what the history, the evolution, how are things present. And with that knowledge, and if you see a substantial number of patients, you can really predict the future of where this is going to go. And importantly, they accept they don't know everything. And it's great to open up and say, look, I don't know the answer to this. And that is often helps you hold, be more esteemed in your colleagues' opinion. It is very helpful to be trained by masters in the field. And it is not too late for anyone, really. If you have an interest in, you could find who do you think is the expert in the field. And not all experts are necessarily good teachers. So you want to go to a place or be with a person who has time for you, can dedicate time for you, and you have a one-to-one relationship. You don't want to be in a large department where you're just one of the people and you spend a year or 6 months or a few months and really get an exposure, but not really in-depth knowledge. And in that period of time, you spend time with an expert which can be anywhere in the world, really. There are so many conditions that are in India or in Asia that are experts. You could probably work on some generic skills like statistics and epidemiology and things like that, and some basic sciences. And then you come back equipped. So I was very fortunate that I could go to Mayo, as Rajesh said, spend time with Brian Weinshenker and Randall Lennon. And with Brian, I'm very close. I still interact very frequently. It's also important to work in a supportive environment and organization. I suspect we're all working in various possibilities, and there are various pressures that one encounters. But a facilitative environment, which certainly help you, and a department that thinks that people want to aspire to improve their careers. It is okay. So you have now chosen a field, you're working on it. You have started collecting your case series, you made an Excel sheet, and you want more patients to come to you. People consider you're an expert, talk about it. Tell others that you have an expert and interest in expertise. And when they have a difficult problem, they know who to contact to clarify their questions. And as you progress, you must have mentors. Mentorship is a big thing now. You probably want someone whom, this is basically somebody whom you can go to and run problems past. They have people who have trodden the same path. They know the difficulties a young researcher is facing, and they can guide you. It's often helpful. It's even ideal not to have somebody in your exact same field to avoid any competition or conflict, but somebody whom we can, have a conversation with and say, I'm stuck here. This problem has happened. I'm having a problem with so and so. How do we solve this? And then, once you are talking in meetings and so on, and you're doing your papers, you really have to soil your hands and start contributing to the field. You have to do research. And hopefully you will have enough patience to do some meaningful research. And that's probably the clue. All of us can put together CDs, but it doesn't really add to the literature. It probably doesn't really help. So think about how does this improve, make the field go forward. And that automatically makes it publishable. It is extremely tempting that once you get into a field, to start working on similar fields. For example, in my field, in NMO, it's autoimmune neurology, isn't it? So I dabbled in encephalitis and other conditions, but soon you will start getting, your efforts start becoming diluted. And there's a saying in English called treat yourself like peanut butter or jam. Don't spread yourself too thin. If you spread yourself too thin, you can't really contribute. So try to stay really focused on your field. Collaborate and create networks. It is really impossible to achieve great things by working in silos. So particularly for rare diseases or unusual problems, you need to have a network. So talk to people, other institutes, other collaborators. And a crucial part is, it is not just you who should shine. There's a saying that rising tide will lift all boats. So make sure your collaborators get due credit. They are acknowledged. They are the first authors sometimes, they're the last authors sometimes, because the goal is not just being at the forefront and being the limelight, but it's sharing it, because you're trying to advance the field, and it will only help your prestige and to do that. This is probably self-explanatory. There are crabs in a bucket. The story is that no crab will escape because one pulls the other down, and this doesn't really help. And this happens all over the world. But once you get out of this mentality, it's very helpful. And it's natural, it's human tendency to be competitive, but beyond a point, it's certainly unhelpful. So build your groups. This is the UK NMO group, the European NMO group, and I'm part of the international group. And if there is no group, then set it up. It's up, you can do that. The other important aspect is, as doctors and patients, we are often, we are distinct. We don't really gel with one another. But I think it'll be great if you're part of patient groups, get involved in patient groups, and they're looking for champions. There could be, Rasmussen's encephalitis group in India, and you could be involved in that, anchor encephalitis, whatever condition. Think about your condition, that particular area, and you could create groups. I set up the first patient charity in the UK back in 2003 as a fellow. I did the first website on it. It took me 2 weeks to do that, but it was very helpful for patients. And when you do work, it's okay to be proud of yourself. And you can pat you on your back and say, it's okay to talk about it too. There is nothing wrong in it. There's often a myth that, give me money and I will do research. And only people who have money can do research. That's not true. It's the other way around. It's the experts who get the funding, and funding is not given to create experts. The very last few slides, you will have lots of opportunities once you're in the field, but don't be afraid about missing opportunities, because if you take everything on, you're going to mess up at least some of them. So behind every failure, there is an opportunity that somebody says, I should have not taken up. So don't pick on everything that you see. But on the other hand, it's important that once in a while this great opportunity comes, this fellowship comes up, or this particular national study comes up, then go for it. So grab that particular opportunity, but don't take up everything that comes your way. Work hard and be nice to people, and generally, everyone will help you succeed. Don't forget to have fun, and don't take yourself too seriously, because ultimately, this is all about, we all have a short work life, and we're trying to enjoy life as a whole. And if you ask most experts, if you ask them, would you rather be a great Nobel Prize winning scientist, or be a known as and a very bad person, or just be a very nice person? I certainly would say that I'd rather prefer to be known as a very nice person rather than be an expert in everything. So don't mix up your priorities, but if you can manage everything, that's great. The last confession, and I'm going to stop now, is this. The greatest success of an expert is in making himself unnecessary. If you do really well, if you can work hard and try to make everybody aware of the illness, make an early diagnosis, treat well, and contribute to the research that everybody knows everything about it, that's great. The expert is not needed anymore. And I'm quite pleased that in the UK, at least, AQP for NMOSD, nobody even calls me anymore, because everybody knows how to treat it. So I'm quite pleased with that. It's not the same for MOGAD, I'm sure, but I'm hopeful that my colleagues will work on that and make it the same. That is my last tip. And I stand on the shoulders of all my colleagues, all my UK NMO experts, Jackie Palace, Isabel Light, our team here, and all my colleagues at the Walton Centre. So thank you very much for the opportunity, and I'll hand back.
Thank you so much, Anu. I think it was just amazing, and I think 135 are still holding back from the 175 we had. Over to Rajesh and Sanjeev, sir. Yes, sir.
Do you hear the claps?
I heard you, sir. Thank you. Thank you, sir.
We're all doing
I'm sorry I overshot my time.
No, it's not a problem. Rajesh, would you want to comment? Yes, sir. It was just outstanding, Anu, and there are a few questions. Would you want me to read it out for you, or would you
absolutely
want to?
Please go. I mean, if you, I have time. You can please
everyone for a second.
Exactly. Yeah.
Unmute everyone for a second.
And I can have that one.
Applause, please. Now you can mute everyone except me. Thank you so much, Anu. That was quite enlightening. I have heard the first part of the talk before, but I was fascinated by your journey as an expert, and that could be quite an inspiration for the younger generation. Thank you so much for doing that in the most professional and eloquent way. Thank you so much. I think Dr. Sanjeev Thomas may have a few comments. Sir, please unmute.
Unmute, and we can't see you fully, sir.
Outstanding presentation of his walk or journey through the NMO, and how we learned over the years of what they have researched. And this is also an example of how a person can pursue a passion and bring out excellent work. And I particularly liked the confession of how things go about. But it's very hard to consider one to be irrelevant at that point. I don't fully agree with that. Well, I think we have questions, and that has to be taken up, a few of them, so I'm not taking more time.
Okay, shall I read it out? You don't need any pronoun anyway. First one is from your close friend, Joy. What have been the CSF findings in patients with MOG meningitis, and do they have prolonged fever?
So the answer to this question is only evolving. Let me say that the majority of MOGs that we see, they might have a lymphocytic CSF. The numbers, CSF lymphocytes are not very high, just like normal MS or NMO. But a small proportion of patients, when they have this encephalitic presentation, they have a large number of lymphocytes. And in a minority of cases, they have neutrophils. In fact, there's a case which I will show another time, where there's actually a case from a child from Delhi whose parents contacted me because it was like NMO. There's cerebellar lesions, but there were the brain lesions, spinal cord, and the CSF was neutrophilic. It looked like some form of unusual, a meningitis. But neutrophilia can be seen in a small proportion of cases. So majority of cases in MOG, CSF may be bland or a few cells, a small proportion significantly lymphocytic, and an even small proportion neutrophilic.
Okay. So the next one is from Rajesh. In our center, that means in Canada, MOG antibody result usually takes 10 days. Once you start IBMP in a suspected MOG disease, at what point, that is in days, you decide patient is not responding to steroid and start on Plex?
Okay. So the Plex depends on the severity of the condition. So if somebody comes to me with who's paralyzed, and I see them, they had numbness, weakness starting yesterday, and today they're paralyzed, and they come, they are having Plex today if possible. Because I know, and we all know, that their outcomes are probably not going to be good. So I give steroids and I start Plex already. But on the other extreme, somebody has mild optic neuritis, they're on day 3 of steroids, and they're already noticing significant improvement, then I don't bother. And everything else in between is shades of gray, depending on what is available, patient can afford. But in general, I would give Plex than not give it. So earlier the better, if the severity is significant. If you worry that this patient will be left behind with disability, then give Plex.
Okay, thank you. May I ask a follow-up question and 2 comments, please?
Go ahead, Rajesh. Yeah.
Okay, so in a child presenting with an encephalopathy, if the brain MRI is normal, is MOG excluded?
At this point, yes, because you almost always see brain lesions. But these reports that we see of meningitis alone, confused patient, having MOG, that's interesting. I guess a small proportion, the brain lesions are so small, but the inflammatory reaction is so high that it causes encephalopathy. But so at this point, I would not test every patient who's encephalopathic, but has no brain lesions for MOG.
Okay. Another comment is when you present, you see the lines on the screen, and I figured out how people do that. So there is an option and there is an annotate section. So we are all adults. I request everyone not to play with that and distract the customer. Kindly don't do that. It's a simple request for future. I have a confession that I didn't mention that Anu Jacob is a great hunter and he owns at least 3 guns. And on weekends, he goes to Scotland for hunting.
You spoiled my reputation now. I have let me clarify that. I have a shotguns, which you can use to shoot pheasants and birds. And I also shoot something called clay pigeon. And it's like a flying discus sport. I have no other violent habits here.
Anu.
Yes.
This is Joy.
Hi, Joy.
I had no connection for some time. I got one question for you.
Yes.
In patients who present with meningitis, anti-MOG syndrome, do they present with fever like any other meningitis, and what will be their CSF picture like?
That's correct. So I think Asha also asked the question. So if it is
Joy's question, yeah.
Yes, I know. So if it is, if it occurs, it must be really rare. I can maybe. Well, this child in Delhi for sure had a fever. So I'm sure in some children where the meningitis does occur, it may happen. But by and large, in MOG encephalitis, fever is not a feature.
And I had a child recently.
Can you hear me?
We had a child recently. Sudeep, a second, just a second. I had a child recently who presented with meningitis. He was treated with antibiotics, completely recovered. And then after about 4 weeks has come with brain lesion, suggestion of demyelination. I had shared that MRI with you, and hope you remember that.
Okay, yeah. So, I mean, listen, this is really important because we don't know of this phenotype yet significantly. There are early reports are coming out. Maybe there will be a series coming out in the near future. I would strongly suggest, I have had quite a few cases like this in the last few weeks from India. I think you should put it together and try to publish it because it is as soon as a case report. It will be really valuable and it may influence how criteria are developed in the future.
Yes, Sudeep.
I know, Sudeep here.
Hi, Sudeep.
Thanks for that marvelous talk. Yeah, my question is that suppose it's seronegative disease, for example, a relapsing remitting MS with frequent relapses, how early should one go for a disease-modifying treatment like rituximab? Do you go by the clinical profile or by the radiological lesion load? And my second query is that you were telling that 1.5 gram is as good as 4 grams. I mean, most of us used to give 6 months apart 2 grams dosage of rituximab. So lower doses suffice, you were telling. And in those patients who are on relaxed rituximab, I mean seronegative disease, would they still be monitored by the lymphocyte count?
Okay.
So first one was how early would you go for rituximab?
Okay.
Yeah.
Let me answer the second question first. So the question is really, if you're going to do variable dosing based on B cell counts, yes, seronegative patients, how often, so did you ask how often we should monitor or when you should start monitoring?
Yeah, so I mean, should these dosage frequency, whether it could be annually or biannually, should we go by the lymphocyte count in relapsing remitting MS?
Absolutely. Yes, so relapsing MS, right? Is it MS or NMOSD?
Yeah, because where the people are not affording, this is a question of great importance. We want to reduce the dosage as much as possible because of the economic.
I think I can answer the question for all conditions. If I was practicing in India, and if I know, and knowing what I know, and patients can't afford it, then I would utilize rituximab as based on B cell monitoring, because I think it is an overkill. If we are confident enough to treat NMOSD, a bad disease, with based on the B cell values, I think we should be even more confident in treating MS with that same strategy. So answering your question, I think variable dosing is fine for NMO or MS, in my opinion.
And the first part of the query was how early would you start rituximab or any other DMT? Would you go by the lesion load on the MRI or the clinical profile?
So this is relapsing MS, right? Relapsing MS?
Yeah, seronegative.
Yeah, NMO negative, relapsing, what looks like relapsing multiple sclerosis.
Yes, perfect.
So by and large, we understand that there is, in the UK, and we have gone from a stage of treating only bad disease to treating early, which is what the US was doing a while ago. So early treatment is what is advised. Right. And if you're going to utilize the B cell monitoring for your treatments, that's even better because you reduce the harm from overdosing while providing protection from advancing disease. I suspect that's a controversial comment because pharma wouldn't want drugs to be used sparingly or irregularly. But I think that is probably the right thing. And if I was the patient, that is, I would be happy with that.
Yes, it would be cost effective.
Can we go ahead, Sudeep?
No, fine. Yes, answer both my queries.
The next one is from Vikas Agarwal. Can MOGAD have leptomeningeal enhancement apart from the aseptic meningitis?
Short answer is it looks like yes. There have been patients that have shown meningeal enhancement, and probably is a reflection of what happens in other things. Even in NMOSD, you can often see leptomeningeal enhancement, but not in all patients. It's a proportion of patients. Yes.
This is from Dr. Sapna. How will you manage seronegative recurrent optic neuritis, and when will you start immunosuppression long term, and how long will you treat them?
So again, this is a clinical question, isn't it? So we don't know the antibody. Is there an antibody underlying it? We don't know. But if the illness has declared itself to be relapsing, that is, it is not one episode. If you have, if you think about it, it's the biology of any autoimmune illness. There is a flare-up of immune mechanisms. You have an attack of some sort. It can be one eye, two eye, but the attack doesn't stop on day 3 or 4, right? It goes on for several weeks and maybe months. And in that period, you might have 1 or 2 attacks. But if you're confident, and in MS, we say 1 month is the gap between 2 episodes to call it a new episode, or one could say 3 months even. But if you have an attack on day 1st month, and then you have another one 8 months later, then it's a relapsing disease. If it's happened twice, it's likely to happen again. So I suppose it's reasonable to put these patients on long term. But how long for is a difficult question. If you have markers like we have in AQP4, where the antibody will predict, or a MOG where the disappearance of the antibody disease is probably quiescent, then you can. With other conditions, it's a question of really 5 years, then start withdrawing and see what happens. Now, this also assumes that these patients are having severe attacks. If it's very mild attacks, so let's say somebody comes to with a mild optic neuritis, they recover completely with a smidge of small dose of steroids. There is no optic dyspallor, there is OCT, the OCT is fine, there is no delay in VEP, everything is great. Then perhaps, do we necessarily need to put this patient on long-term treatment? Perhaps not. So you should think about the biology and the repair mechanisms in an individual patient. And if you take the example of myelitis, you had a bad attack of myelitis, you do a scan after 3 months, and there is atrophy already. That means that the repair mechanism is not good. So you probably have thinking of, I really need to prevent this attack from happening again. But if somebody's made a complete recovery, there are no signs, maybe that person's biology is such that they will recover better next time too. So your spinal cord reserve, shall I say, is probably higher for those patients. So it has to be titrated based on these factors.
Next one is rituximab is more useful in NMO. The role of alemtuzumab in NMO and MOGAD. The comparison.
Yeah. So alemtuzumab is not helpful. It has been known to exacerbate many primarily B-cell mediated conditions. That includes NMO. So I know Alistair Coles, my colleague in Cambridge, has given alemtuzumab for AQP4 NMOSD, and his patients had significant relapses. I suppose the mechanism is similar to what you see for other alemtuzumab mediated B-cell autoimmune conditions like thyrotoxicosis and the good pastures and so on. Now, for MOGAD, I don't think we know the answer yet, and I wouldn't want to say it's not useful or it causes problems, because it's a fantastic drug in some patients. So we'll have to wait and see. And if somebody wants to try out, assuming there is no literature that is against it, it's probably worth. And whatever be the outcome, try to write as the case report so everybody else will know as well.
Okay, thanks. So we have a last bunch of questions from a single person. It's my senior resident here, Dr. Jaffer. So I'll take one by one. Why MS drugs worsen NMO?
Why do they worsen it? So, well, the short answer is we don't know. But the longer answer might be, it all boils down to basic immunology. TH1, TH2. I mean, I don't think I understand. Well, nobody really understands. It seems to drive the mechanisms that drive B-cell hyperactivation. I think I published a paper on Tysabri worsening AQP4 NMOSD. And one of the hypotheses we said that was Tysabri may prevent, because Tysabri acts by preventing the entry of lymphocytes into the central nervous system. That can be the bad lymphocytes or the good lymphocytes too. So if you prevent the good lymphocytes, the regulatory cells from entering the CNS, then if it's a B-cell mediated disease, then probably those that can lead to the unchecked activation of the B cells. So that may be an explanation why Tysabri worsens NMO. But the other drugs, I don't know. Jackie Pallas has done work on beta interferons worsening it, and interferons tend to drive some of the B-cell activated diseases, the beta interferons. So that may be an explanation too. But overall, I don't think we clearly know.
The second query is, what is the chance of getting antibody positivity after immunomodulation, say 6 boosters of rituximab?
Repeat that.
What is the chance of getting antibody positivity after immunomodulation? Say, for example, 6 boosters of rituximab.
So here's the patient who come to you with NMO and the AQP4 antibody positive. You give rituximab. What happens to the antibody after 6 doses? well, the antibody is still there. You can detect it in the serum. So it doesn't really go away, at least for AKP4 NMOSD. As I told before, there was a patient who had NMO. I gave her 10 years of azathioprine, and the poor lady got leukemia. So then she had an allogenic bone marrow transplant, and I hope that will cure her, because replace the whole bone marrow. But 3 months, I think the first sample we did after she came, the antibody was still there. So we have not really managed to eliminate those disease-causing B cells, plasma cells from the circulation. So she still is on low dose of prednisolone. She doesn't want to take azathioprine anymore, of course.
So, quick 2 questions more. What is the most probable localization for hearing loss in NMO, in the neuraxis?
Correct. So I think it is the cochlea. It is the cells in the cochlea which express astrocytes. Now, AKP4 is a water channel, isn't it? So many cells require transport across the membrane, and there are AKP4 so every cell that requires to transport water will have AKP4 or one of the AKP4 molecules. There are about 20 of them. So yes.
Okay. I think we'll go for the last one. How will you treat your itching, pruritus and NMO?
So I think you have to treat the underlying condition, really. If itching, so usual stuff with treating the underlying inflammation, the root cause. But then you go ahead and use cetirizine and drugs that act on the spinal cord, essentially, modulate the spinal cord. And we have tried, apart from histaminics, we have also tried Keppra, topiramate, the drugs that you would use for tonic spasms, carbamazepine and so on. Because the reason for the myelitis seems to be reason for the itch in myelitis is the spinothalamic tract axons. It's the transmission in the spinal cord. I actually have a new syndrome coming up, new symptom coming up in the near future. Hopefully, I can tell you next time. Something unique not been described, actually. Okay, we'll see.
Closer to itching, I suppose. Yeah, the last question before we wind up is, in the setting of COVID, what is your advice on starting immunosuppressants in NMO?
Okay, so very interesting question. A lot of data is coming in, but overall, I can say that it seems that B cells don't seem to play, or rather humoral immunity doesn't seem to play a big role in antiviral, into COVID at least. And why I say that is because in a condition called Bruton's gamma globulinemia, where there are no B lymphocytes, so they're not producing it, they have had COVID and they've recovered completely. So even in the absence of antibody production, gamma globulinemia, patients have done well. So to me, it is reasonable if there's a need to start rituximab, ideally delay if you can. The patient can manage with steroids or such, that's okay. You can hold while but somebody needs rituximab, then I think you can go ahead and treat. And that is what has been happening for both ocrelizumab and rituximab. We have in patients who really need the drug, who's having a relapse, or their B cells are now climbing, they're 10%, the last relapse is quite bad, we are retreating. The other drugs, perhaps lesser so, but again, overall, in fact, some of the reports say that some amount of immunomodulation is actually helpful in COVID, because as you will well know, much of the lung damage is because of autoimmune inflammation rather than the virus itself. So it's, in some cases, it's simply protective as well. So both aspects.
Okay, that I think almost around 15 questions more, but in the interest of time, we'll post it to you directly from the so-called spectators here. So over to Sanjeev sir and Rajesh.
So before we conclude, on behalf of...
1 second, Rajesh. Anu's teachers are all here. I think Nair sir is here, Suresh Nair sir, Sharada madam. Would you want to unmute all of them and let them come up, please?
I think they have to unmute themselves. Or...
Yeah, they're doing it. Nair sir, Suresh Nair sir, Sharada madam, at least these many people I can see here.
Anu, great talk. Dr. Anu,
Thank you,
You
sir.
are a
Thank you.
champion. You are a champion.
You're
There's
very
no
kind,
doubt
sir.
about it. The way you have handled the questions and, and studying the immunology of the disease, it's a really fantastic and roadmap of being a researcher. I think the younger generation will be really motivated to take neuroimmunology or maybe autoimmune immunology in a big way. Thank you so much for sharing your experience.
My pleasure, sir. And that'll be the biggest achievement I can say. Somebody
my
is
good
inspired
wishes
that.
to you. I always remember the way you used to, I remember when you said your first confession that you were anxious, so I went back in time and I felt that you were indeed, you were a little anxious, which was not at all needed. Okay.
No more
Anyway,
confessions, sir.
you have
Sir, you are
outgrown.
giving out several secrets.
You have outgrown. He confessed, first confession.
No, he has confessed. So he was anxious about our. That's what
that was probably, he was, I don't know what was the reason. Probably maybe it's intrinsic. Some people are like, suppose I go on stage, I get a stage fright, I get a stage fright. So those kind of things, and.
Sir, we must have gone through the audience.
Yeah, lovely. Good, sir, that you have talked about.
Yeah. Thank you so much, Anu. Really a pleasure that you have achieved so much and such a big team you have formed. And really, I was completely, as Asha was saying, astounded by your presentation. Really astounding. Thank you so much. Thank you.
And for all of you here, it's Sir's birthday today. Why don't you all wish him a happy birthday?
Happy birthday, sir.
Nice,
thank you. Thank you so much. Thank you. You have given me a lot of happiness. Thank you. Thank you, sir.
Yeah.
Thank you.
Is Sharada madam here?
Hello, Anu. Can you hear me?
I can hear you, madam.
Okay. Oh, I know such an amazing presentation and presented with so much
Please
of.
open your video.
I'm not able to do that. I got disconnected also in between, so I'm really facing problems. Anu, you had told about alemtuzumab. I'm still audible, no?
Yes.
Yeah.
Hello, Anu.
Yes.
You told about alemtuzumab. What about the other 3 monoclonal antibodies you mentioned? You are using it. You have started using it.
The 3 new drugs for AQP4 NMOSD?
Monoclonal antibodies, 3 MABs.
For NMOSD?
NMOSD.
So eculizumab.
Eculizumab.
Eculizumab, I was the UK chief investigator. So we have 2 patients on eculizumab and they have done really well.
Okay.
Inebilizumab and satralizumab have not yet come into the market. Eculizumab is already available for other conditions like PNS, proximal nocturnal hemoglobinuria and myasthenia. And they are using it in the US. It's very expensive though.
So such an awesome presentation, Anu. Congratulations, hearty congratulations. But happy birthday wishes to Dr. MT Nair also. Okay.
Anu, you can share your email ID to everyone. There are lots of questions coming up. They'll be directly contacting you for that.
Yes.
So over to Rajesh and Sanjeev sir to wrap up the whole thing.
Okay, so thank you everyone. And on behalf of batch 1999, we thank Dr. Ashalata and Dr. Sanjeev Thomas for giving us this opportunity, and we were chosen as the first batch, so that is quite an honor. I hope you continue this practice, and in June we look forward to presentation from other batches. Anu, as always, fantastic. Thank you so much.
Sir, one last.
Yeah. Very good. I think it was overall we have enjoyed our evening, and this series of 3 lectures are over. So actually, this was a very successful one. I think every participant had enjoyed it. It is mostly our alumni who have done it. And I think, Asha, we will have to discuss how we will be continue. We need to continue this. My suggestion is that so frequent can be avoided, maybe twice a month or something like that would be good. So that, we can come up together. And I also have a feeling that, some of the alumni may not be to others because we are now over 25 years. So a wide spectrum is there. So maybe as we did now, someone should introduce and briefly talk to them, converse with them, and others can know how they studied here, lived outside, what their way. Those things can be also brought out. So some sort of a short interview with the speaker before we start this talk, maybe putting the things in the right setup. We can think about it, and maybe better ideas will come up, and maybe we can do that later. Thank you.
Thank you, sir. Right.
Thank you, Anu.
Thank you, Bob. Bye.
Thank you.